Hello YouTube, my name is Stefan Hartman, physician assistant, and today I'm going to be going over a discussion on pulmonary embolisms. As you can see by this presentation, this was done back when I was a student and it was part of my master's thesis. Can the risk of pulmonary emboli be predicted? It is a current hot topic due to the increased risk of blood clots associated with the current vaccines in circulation, the COVID vaccines. So we're going to be going through the known risk factors for pulmonary embolism and how can we predict these, because it's a tough diagnosis, one of the most difficult ones in medicine, and unfortunately a deadly one when missed, and it is often missed, unfortunately. So much so that the Surgeon General a couple of years ago declared it a pretty big problem that needed to be addressed. And even myself in clinical practice, I've encountered them a couple times and caught them based on some of these criteria, but not all of these. See, that's the thing. With these pulmonary embolism, you have these lists you can run through, but they don't catch them all. And sometimes you have to rely on your clinical intuition, which we describe as Gestalt, which we're going to get into. And I'm also going to tell you about those cases that I caught thanks to my clinical Gestalt and my research of pulmonary embolism as a student. So, for the medical professional, the ability to suspect or rule out pulmonary embolism before symptoms develop or in the absence of symptoms remain an elusive objective, although PE is the third leading cause of cardiovascular disease. Research has flourished since the Surgeon General's call for action to fight pulmonary embolism in 2009. So there are three common screening modalities: the Wells, Geneva, and Gestalt. And these are used along with the PERC rule, which is the pulmonary embolism roulette criteria rule, to stratify patients who come into emergency settings and complain of vague symptoms. But even using these tools can miss pulmonary embolism. Newest research on the risk for PE is done on a wider range of factors and on subdivisions within those factors, and on specific subgroups of patients, and such as location of and type of surgery, such as the specialty that you're seeing the patient in, and even genetic factors such as factor V Leiden deficiency. Kline and Kabrehl, Kline has been doing a lot of research on pulmonary embolism, identified 16 risk factors with considerable detail. The PERC superficially contains about 9 of them. The Wells has 7 and Geneva has 8 of these risks. There's discussion in recent literature about the increased risk of pulmonary embolism in women. Baum, 2014, made a controversial proposal that all women should be screened for hypercoagulability mutations, and I would add especially when being put on hormonal therapy. As we'll see quite soon, that is a risk factor. So here is a table, comparative analysis of risk factors from Kline and Kabrehl. Any factor in one traditional scoring system not included, and then a couple more. Let's see. Let's look at the Wells. Wells states that alternative diagnosis less likely than PE. That's one checkmark box that you can write off and say, well, this might be a PE. Heart rate above 100. So PERC rules out PE if the heart rate is less than 100. I found this to be quite unreliable in real life settings. Geneva says a heart rate greater than 95. So yes, anytime you have a heart rate above 100, something's off. It's not just that the patient is anxious. Usually there's something physiologically wrong. But it's a very poor tool to use. But in conjunction with other things, it can help us lead us toward the correct diagnosis. You suspect a DVT, and that's a pretty big one. How would you suspect a DVT? Well, calf swelling, that's a big one. Calf pain. Hemoptysis is in the Wells criteria. That's coughing up blood, and that's a big red flag if you ever see that. Usually it's not that easy. PERC rule out, no hemoptysis, and Geneva uses hemoptysis as a scoring system. Let's see, unilateral leg swelling, that's always one you have to look out for. Everyone kind of agrees on that. Pulse oximetry greater than 94% is a PERC rule-out. I have found this to be also unreliable in real-life settings, and if I relied on this, I would have missed a PE. So Kline and Kabrehl say that males are 2 to 3 times higher risk of recurrent venous thromboembolism. So if a man has had one before, they're more likely to get another compared to women. Age greater than 50 increases the risk every year and levels out at about age 80. This is also not a given true answer, because the 2 patients that I personally witnessed were younger than age 50, much younger. What does PERC rule out say? Age less than 50. You can rule out a PE agent. You can see how these sometimes don't agree. And then the Geneva adds a risk if they're older than age 65. Sure. Prior venous thromboembolism, that's probably the one biggest risk factor, is prior PE or DVT, especially if it was unprovoked. Now, say a patient had an 8-hour spine surgery and they got a blood clot in the next day after they went on a trip across the states, right? That would be called a provoked PE. You had a surgery, you're in hypercoagulable state, and then you go on a long car trip, bam, that's provoked. An unprovoked PE or DVT is where you suddenly have it out of nowhere and you had no risk factors for it and you got one. That's something to consider, maybe even genetic mutations or what the hell is going on here. So if you have a spontaneous DVT or PE, that puts you at much higher risk of getting another one rather than a provoked DVT. Let's see. Highest risk in men, especially if D-dimer remains elevated. So D-dimer is this blood marker, kind of a controversial blood marker that is used in the emergency department settings. It can be ordered, and if it's high, it really just sends you down the road of ordering a CAT scan with contrast to rule out a pulmonary embolism. If the D-dimer is low and normal, then it kind of eliminates the possibility of PE. Unfortunately, D-dimers can be elevated for a variety of reasons, and if you are suspecting a D-dimer or suspecting a blood clot which would make you want to order a D-dimer, you probably would just want to get a CAT scan anyway. Solid cancers. The risk is greatest with adenocarcinomas and metastatic disease. This is well known that cancers increase the risk of blood clots. Hematologic cancers, acute leukemia and myeloma, confer the greatest risk. Yes, so active malignancy is a big risk factor. Thrombophilia, such as factor V Leiden deficiency. This is actually not that uncommon, and that's why one of the researchers suggested that all women be screened for factor V Leiden deficiency before being put on contraception, hormonal contraception. Recent surgery and major trauma. Yes, these are big risk factors. The highest risk they noted was 10 days after these incidents, these events, right? What do they say here on the Geneva and the PERC? So the PERC says no major surgery, endotracheal or epidural anesthesia, and you can rule out PE. The Geneva says major surgery or anesthesia or a lower limb fracture is a big risk factor. Extreme immobility, so acute limb immobility of 2 contiguous joints or flaccid paralysis confers the highest risk. And travel. Risk increases with greater than 6 hours of continuous seated position. So yes, that's why many patients hospitalized are put on heparin, which is a blood thinner used to treat DVTs and PEs. So they often just put patients on this, especially in surgery. When patients are having surgery, they're given heparin, just because these 2 scenarios, hospitalization and surgeries, cause DVTs and PEs so much, they just anticoagulate the patient ahead of time. Bed rest, yeah, the biggest risk factor is 72 hours of bed rest. Indwelling catheter, so upper extremity indwelling catheter, okay. Not very common. I guess that won't happen too often. Smoking is a population risk factor, but not a factor in the ED setting. They just figured this out, the statistical analysis. Who can explain why this is? but smoking is a population risk factor for pulmonary embolism according to Kline. Congestive heart failure. So it's a population risk factor for PE that may be less important for the emergency department, related primarily to severity of systolic dysfunction. Stroke. So risk is greatest in the first month after deficit. So this makes sense, right? If you had a stroke, you might be more sedentary, maybe your limbs aren't working as well, you're probably sitting around a little bit more. This, if we look at the previous risk factor of immobility, would obviously increase the risk of stroke. It really just goes back to immobility. But if you had an ischemic stroke, there could be another reason for it as well. That might need to be looked into in greater detail. Estrogen use, here we go. Highest risk period is in the first few months after starting therapy. All contraceptives containing estrogen increase the risk of venous thromboembolism, aka a blood clot. Obesity and metabolic syndrome. In the general population, VTE risk starts at a BMI greater than 35 kilograms per meter squared. So that's a decently elevated body weight. And the reasons for this are unclear. Perhaps more sedentarism, maybe higher inflammation related to increased visceral adiposity. We're not sure why this is, but it is a fact. Pregnancy and the postpartum state. 70% of all peripartum PEs occur postpartum. The risk increases with trimester. Now, personally, I saw a PE in a postpartum patient. The patient had come in to the urgent care complaining of a cough and a bit of shortness of breath. She also had a fever. Looking at her, her lungs had a bit of a wheeze to them. She had no swelling in her calves. And right to the side of her was an infant. She had brought this newborn baby with her. I think the child must have been not older than a couple weeks. The patient had a bit of inspiratory chest pain. I said, "Does it hurt to take a deep breath in?" And she sat there and she breathed in. And she was like, "Yes, it does hurt." And I was like, maybe she has a blood clot. Well, let's do an x-ray here. I did an x-ray, and the x-ray showed an infiltrative pattern. It kind of led me down the pneumonia road. Maybe this poor girl, she got a pneumonia. Could explain her chest pain, her bit of shortness of breath, and her cough. And it's adding up a little bit more. But something was just not sitting right with all this. And I try to avoid irradiating young women, but I said, look, we need to rule out a pulmonary embolism. Let's get you a CAT scan with contrast. So I did a CT angio, and the radiologist called me up within a couple hours and said, "Hey, we have a pulmonary embolism in a young girl here. What's going on?" I said, "Wow, this is a big deal." And I brought the patient back in, and I started her right in the clinic on Xarelto, which is a novel anticoagulant agent used nowadays quite easily compared to the previous or historic use of warfarin, which is a complicated drug to use, full of blood sticks and monitoring, and you can't eat leafy greens and so forth. So this patient had a good result, good outcome. She also is given antibiotics just because the radiologist couldn't completely rule out a pneumonia, and she was still having a bit of chest pain. She got antibiotics as well as anticoagulant. A whole lot happened for this poor girl. Let's see, what else here? What does Kline say? Non-infectious inflammatory conditions. Very interesting here. The examples of inflammatory bowel disease, lupus with lupus anticoagulant, and nephrotic syndrome increase the risk of venous thromboembolism, roughly in proportion to severity of underlying disease. So these are generalized autoimmune conditions that affect pretty much every tissue in the body. And we're seeing here that when you have such high inflammation from these autoimmune conditions, they'll increase your risk of pulmonary embolism. Now, there's a lot of autoimmune diseases out there that cause inflammation. We can think of psoriatic arthritis. We can think of inflammatory bowel diseases such as Crohn's and ulcerative colitis, obviously the lupus, and perhaps many more. So this opens up a whole realm of possibilities for creating PEs when you have a high inflammatory state. Now let's talk about the other patient that I identified as having a pulmonary embolism that really didn't have many of these risk factors. So the patient was a younger male. He came to the office and he again had a cough, had a shortness of breath, had sputum as well. He was coughing up junk. And he also had a swollen leg. His leg was pretty hard as a rock almost. Hurt him a lot for me to push on it. I did a chest x-ray, and the chest x-ray again threw me off, showing an infiltrative pattern consistent with pneumonia is what the radiologist read. Now, if you look classically in the literature, you'll see a Westermarck sign or a Hampton's hump. This is a kind of a rare thing that you see on imaging. I think this patient may have had it, but the radiologist missed it and kind of led me in the wrong direction. But I saw this swollen leg and I said, look, I know you're hacking up stuff. I know you got a fever. His heart rate was a bit high. His oxygen was a little bit low. It was about like 95, 96. It wasn't one of these criteria that we looked at earlier, but it was enough to make me order an ultrasound of his leg. Lo and behold, he had a DVT. Sent him right then to the hospital. They did a CAT scan, and he had a pulmonary embolism, quite a big one as well. And his only real risk factor was he worked in an office. So he sat in a chair. He actually worked from home. He sat in a chair, worked from home. And I asked him, how long do you sit in this chair? And he said, I sit in the chair for 8 hours. And I said, do you get up and walk around? Do you get yourself some coffee? He's like, nope. I sit in the chair full 8 hours working until I'm done. So that most likely caused his DVT. Moral of that story is walk, get up and move around a bit. So I like the British Thoracic Society's pulmonary embolism risk factors. These are pretty comprehensive, pretty good. They like to talk about post-operative states, major surgeries, obstetrics, so late pregnancy, cesarean section, lower limb affections, that's a British term, affections, fractures, extensive varicosities, so varicose veins, so big varicose veins, or maybe even small ones, but all over the legs. This, they say, is a risk factor for VTE. Malignancies, we talked about that. Limited mobility, hospitalization, geriatric care. Miscellaneous, prior PEs, that's an easy one. Cardiovascular, congenital heart disease, heart failure, hypertension, so high blood pressure, and superficial venous thrombosis, and central venous catheter. So the hypertension one is one that you don't see in anywhere else. Just the British talking about high blood pressure as a risk for pulmonary embolisms. Humoral. So humoral, what kind of word is that? It's another interesting British word. Estrogen use, yes. Oral contraception. Hormone replacement therapy. So this may cover things such as testosterone replacement, maybe estrogen replacement, progesterone replacement. This is kind of a broad category they're using here. Miscellaneous chronic obstructive lung disease, so COPD, a lot of people have that. Neurological impairment, latent malignancy, thrombotic defects, long distance travel in a sitting position, and obesity. Yeah, we've seen these before. Other inflammatory bowel disease, nephrotic syndrome, chronic dialysis, myeloproliferative disease, paroxysmal nocturnal hemoglobinuria. So that's an interesting one as well. I do like the British Thoracic. If you're going to just use one risk, I wouldn't use the Wells. I wouldn't use the PERC. I would probably use, if you're going to choose one, the British Thoracic Society guidelines. You just look at that and add these up, and that's going to be a pretty good one to use. Yeah, and this is agreed in the literature. Balalovic, can't pronounce that, found the British Thoracic Society to be a more comprehensive predictive tool when looking at all of these. Corrigan et al. Identified the most commonly acquired risk factors as advanced age, poor circulation, high body mass index, smoking, history of joint complaints, cardiovascular pathology, and previous DVT or PE, and immune system issues. That's pretty comprehensive as well. Women at increased risk. Yes, so Corrigan et al. Found women taking oral contraception makes PE 4 times more likely. The greatest risk of PE-related pregnancy occurs 2 weeks postpartum. I think I saw my patient who had the PE 2 weeks postpartum as well. Baum 2014 proposed screening all patients for factor V Leiden. I would say especially women who are thinking about becoming pregnant, who are thinking about taking estrogen-based contraceptions, or taking estrogen replacements. Pregnancy relates to a 5-fold increase in probability of VTE. Oral contraception correlates to a fourfold increase in VTE, according to Baum. So conclusions, traditional risk factors are ineffective in completely figuring out who's at risk for a PE. I think one of the best ones that a clinician can have is Geneva. So, not Geneva, Gestalt. Gestalt, another G one. Gestalt is a German word for your intuition, what you think is going to happen. And if you've researched pulmonary embolism a lot, you have a pretty good intuition. If you've seen these before, if you kind of know what to look for, you can trust your gut instinct is probably the most effective tool in figuring out if someone has a pulmonary embolism. I mean, that might sound kind of scary to most people, that you have to trust your gut rather than relying on some algorithm or some computer program, but that's just the case here. Pulmonary embolism is a tricky one. In the US, we perhaps even over-test for it just because no one wants to miss it, but I can understand that over-testing paradigm just because it is so hard to diagnose, and missing it typically results in the death of the patient, and no one wants to have that. So we do have a system of over-testing. So a lot of CAT scans are ordered unnecessarily, a lot of ultrasounds are ordered unnecessarily. Say ultrasound has the least harm to it. It has no radiation. The CAT scan does have harm to it. It is radiation. You are putting contrast in someone. You're doing something to someone. And yeah, so there's risk and benefits towards testing and not testing. I would say if you have the risk factors, if you've listened to this lecture that is a pretty comprehensive one. I think it kind of covers the whole realm of risk factors for pulmonary embolisms. If you're interested in reading the paper, I can forward it to anyone interested. This table will be up for anyone to look at as well. And the references as well, I have an extensive list of references. You can read any of the source materials in the document. Hope you all enjoyed. I know that was a lot, kind of complicated, but pulmonary embolism is complicated. Talk to you all next time.